Yeah, so most studies that have and efforts that have focused on predicting preterm birth use factors like obesity or poverty or race ethnicity that you really can't do a lot about. And what we've learned over the years is that pregnant people, as well as physicians, really want to use factors that have action attached to them. So the preterm birth actionable risk index, which we call the PTB-ARIx, leverages factors that we know have associated therapies associated with them. So things like gestational hypertension, pre-existing hypertension, diabetes, asthma, mental health conditions. Those all have therapies that could be helpful to pregnant people and reduce risk. Things like low dose aspirin or using a continuous glucose monitor or an inhaler for your asthma or medications and therapy for mental health conditions. So what we essentially did was combine over those factors to create a prediction score for preterm birth, which ended up functioning really, really well, both in the first trimester and second trimester. So surprisingly, these therapies, things like low dose aspirin for pre-existing hypertension, or even using an inhaler for asthma, the uptake of those, and what I mean by uptake is the percentage of people who have the condition, but use it during pregnancy is less than 1 in 2. So we're hoping using something like this actionable risk index is a way in which we can increase the number of people that first of all, know about their risks. Second of all, know about the therapies that might be useful to them. And third, increase their use. So, of course, physicians now are looking at things like pre-existing hypertension or asthma or mental health conditions. And what this tool we're hoping will do is allow them to kind of look at the whole picture, right? And use it as a way to encourage that conversation with pregnant people about what factors they have, what interventions might be helpful to them, and then essentially help them understand those factors, and then track over time whether they're using those interventions. What we've learned, for example, are that while sometimes physicians might say, aspirin may be of use to you, there's not a lot of conversation as to why it might help the pregnancy. So, for example, people might say, you should take aspirin during pregnancy because you have this risk factor, but they don't go the next step, which is taking aspirin can increase oxygen to the growing fetus, help ensure good growth, right? And what we've learned from pregnant people is that when you have that second part of the conversation, they're more likely to use aspirin. So really, it's this conversation between clinicians and pregnant people that we hope that the REX will help with. So we know that those conversations can be very, very short, right? So anything we can do to facilitate kind of understanding of risk and other things that may help with a healthy pregnancy would be really helpful because there's just so much to talk about. And what's really difficult is we know if you have multiple risk factors, so let's say you have hypertension and diabetes and a mental health condition, or you have homelessness or intimate partner violence at home, that's a whole lot to talk about. So, but the more of those factors you have, the higher risk you have. So it's kind of that it's not like, well, when multiple factors show up that now you get 30 minutes or 60 minutes with your provider. It's still often 15 to 20 minutes. So any kind of communication tools that can bridge those gaps may be especially useful for people that have multiple risk factors.